Hello everyone, my name is Russell Linville and I will be one of your professors for this course. I appreciate you guys trusting me and helping you with this course. This is going to be a lot of fun for not just me, but hopefully you as well. And to give you a little background on myself, I am a 9 years out practicing physical therapist. I graduated from Franklin Pierce University in 2013. Does that make sense? Yeah, I think coming up here will be 9 years in 2022. So my background is primarily in sports medicine. I did a sports residency following graduation, and then now I work up in Minnesota, where I work at the Minnesota Vikings training facility, and we see professional athletes not only with the Vikings but also any athletes that are in the upper Midwest that are looking for a training facility. And of course, we see a lot of general population as well as high school athletes as well. So that's a little my background. Of course, over over the term here, we will get to know each other a little better. I will have office hours and things posted, and my boots on the ground back home in Arizona there for you guys is, of course, Dr. H and the other Dr. H, Dr. Harris. And so if you guys need anything, they can help facilitate to get you in touch with me. Also, if you check the syllabus, my contact info will be there. And likewise, if we make our way through here on the PowerPoint, let's see if I can manipulate this a little bit good. Forgive me this first recorded lecture, as I'm not used to the technology quite yet, but we'll figure it out. I've been messing around with it, so we'll get after it. So anyways, my contact info, the best one to get in touch with me is actually my work email. It'd be russelllinville@traininghouse.com, or my Franklin Pierce email. There's a little typo there, unfortunately, but linvilleb11@live.franklinpierce.edu. Of course, I'm fine with you guys adding me on social media, just if it's going to be more class oriented, just shoot me an email, a little more official means of communication. But in this day and age of social media, I think it's okay for us to connect that way in a pinch. So appreciate that. So let's talk about this lecture. This is a lecture about red flags, and hopefully there's been some exposure to red flags thus far for you in your curriculum. If we just think about what red flags are, those are things that might throw up an alert signal to you, right? And so if we think about the objectives for this lecture, we want to identify common red flags in various body regions, determine appropriate course of action following red flag screenings, treat versus treat and refer, or just refer out. And so we'll talk about what to do in certain situations, and then learn screening tools and clinical prediction clusters on how to assess if it is a red flag or not. So what are red flags? They are findings or symptoms or conditions that may require immediate attention and supersede physical therapy being the primary provider of service. They're typically indicative of non-mechanical or non-neuromusculoskeletal conditions or pathologies, and could be of visceral origin. Common red flags are reports of trauma, fever or chills, unremittent night pain, bilateral symptoms, and unintentional substantial weight loss. An affirmative response to a single red flag question may not be reason for an immediate referral, but a cluster typically could and would be. So this is straight out of your Dutton book, and a lot of this information is. You guys have access to this, of course. So just to touch base on this, one red flag, as that last bullet point shows, one red flag is not enough to be suspicious of something insidious going on. So by the end of this lecture, hopefully we will have an idea of what grouping or clusters of different things makes it so that we are very suspicious of something more going on. So you have a patient in front of you, new evaluation, you're 2 days out from graduating from PT school, and you just passed your boards, and you sit down and you go, I wonder, how do I even screen for a red flag? Well, there's many different ways, and one of the things is intake paperwork. So for those of you that have worked as a PT tech or in a PT clinic under some or even maybe medical clinic for some, practice, that these patients that come in, they will get paperwork to fill out. It is very tedious. The patients don't like it, typically. And there's a lot. It's a lot of paperwork. So, obviously it's things like your billing information, insurance information, etc. But there is really valuable information in intake paperwork, or there could be, if your practice is set up that way, for you to learn a lot about your patient even before you see them in front of you. So intake paperwork is important. If we look at the picture on the right, this is an example. It's a nice stock photo, but it's still a good example of body region specific areas where the patient can circle or draw or write where their pain's at and give you an idea. So if someone comes in and says they have hand pain, but they draw a line from their neck all the way down to their hand on both sides, you're going, well, is this truly hand pain, or is this person dealing with something like radiculopathy? So it can be valuable in the fact that it shows you and starts getting the mechanical gears turning of what you may think this person's dealing with before you even sit down, so you can gather your thoughts a little bit. Okay. The big one here, and I've bolded this for obvious reasons, is that your subjective questioning and reporting are probably the number one thing that's going to help you screen for a red flag when there's a live patient in front of you. The questions you ask will help go down a path, hopefully a good one, of if this person is appropriate for physical therapy or not. And that is your main job as a physical therapist, especially a new grad, in the context of screening for red flags. Is this person safe? Is this person appropriate for physical therapy? Okay. So with that said, you are also supposed to take things like vitals. Now, if you get a young, healthy athlete in, maybe they just had surgery, okay? Could you assume that their vitals are pretty normal? And yes, probably. But what we've done at my clinic is gotten into a habit of starting to take blood pressure on people, and that also will give you their resting, pulse. So they make these little wrist devices now that are blood pressure cuffs, essentially that, hey, welcome to physical therapy. My name's Russ. We're going to put this on. It's going to measure your blood pressure. It goes on. 30 seconds later, it's off. Then you can start your exam. So you've taken 30 seconds out of your day, and now you have a little bit of more objective measurements on their cardiovascular health just sitting there. And then finally, don't discredit your clinical suspicion or your intuition, or if you feel uneasy about it, or kind of those times where the feelings of hair standing up on the back of your neck. And so when in doubt, refer out. That's the old saying. So I've had many times in my career where something just didn't seem right for me. There's just something that was, I don't know, I couldn't put my finger on it. And I referred out, and 90% of the time, my intuition like that has come back and everything's been fine. But the 10% of times, or whatever, for example, that comes back that's not, it makes me feel really good that we referred out, got the person a little more help, a little more screening by someone who has a different style practice than me, physician or otherwise. And it was the right thing to do. So on that topic, do you treat and refer, or is it an immediate referral? So this is an example of a schematic that helps you determine, and this is not something you need to memorize, okay? This is something I want you to try to work your way through and to the best of your ability, try to understand it conceptually, but don't memorize this, okay? Please. This is not going to be on the test. Fair. But this is how you should interpret what you do as a therapist and what the patient, does as a patient, and how you two work in coercion with each other to make them feel better. So if you start on the left, top left, see it says the word therapist. So if you work our way down, you're going to try to gain information, perception, interpretation of the patient. You're going to formalize your initial concept, and maybe you have multiple hypotheses of what's going on. And this all comes from the patient on the top right, who has their own presentation, their own hypothesis. You two work together in that top row on data collection. That's the subjective interview and physical examination. In the therapist column, after that data collection and your hypotheses being formed, you're going to move into your evolving concept of the problem. So you've gathered more data. Now you understand maybe what's going on through a physical exam, subjective exam, and you keep going. You start making a decision, diagnostically, or you're going to do some special tests to try to narrow this down, and then how do you manage the case? Meanwhile, you can go over to the patient side as you're developing your concept or problem and explain this to the patient. Now their idea is evolving. Their idea of their issue is evolving, and they're starting to understand it more. Their understanding of the diagnosis and the management plan. So your physical therapy intervention there on the second to the bottom column in the therapist column there could include things like education, home exercises, treatment strategies, participation, learning, etc. Okay, and then finally, that is your treatment. And so you see where you go, see where the patient goes. And if they're doing well, they get all the way to the bottom right, which is finally you get to a point where you guys can review self-management and increase the patient's self-efficacy. So this again is a little bit of a outline of what a normal or hopefully normal situation of a patient-therapist relationship is. And when you throw a red flag into the equation, that'd be more under your data collection box. That kind of throws a cog or a wrench in the wheel and kind of blows this up for a little bit. So let's talk about that. So there's a paper that came out in the JOSPT. I know I'm going to mess this author's name up. Laura Finucane. It's titled International Framework for Red Flags for Potential Serious Spinal Pathologies. And so what they've done here, if I move my little box around here, is they try to create a decision tool for early identification of serious spinal pathology. So in this study, they wanted to, 1, have a tool that has 3 steps. 1, determine your level of concern. Consider the evidence to support red flags and the individual profile of the person's health determinants, example like their age and sex, to determine your level of concern or your index of suspicion about the presence of serious pathology. 2, decide on your clinical action based on your level of concern to determine in step 1. And then 3, consider the pathway for emergency or urgent referral. Know your local referral pathways and pathways to access specialist care if needed. Very good. Let's see, can we keep going? Yes. Figure 1 in this study is a good representation of how my mind now as a clinician nearly a decade out works. In the blue, you have things that are your subjective, where you have what's the prevalence, or I should say, maybe not necessarily subjective, but the evidence. The prevalence of pathology of the person in front of you. Do they have any red flags that are supported by high quality evidence versus any red flags that are just supported by consensus or red flags in combination? So you're trying to determine which bucket they fall in. Then I guess that would be orangish peach color. That's their clinical profile. So when you're talking to the patient and you're figuring out their symptoms, have their symptoms progressed? What's their response to care been? Maybe you have treated them for 2 weeks and they're not getting any better. What's the cost of delay or the consequence of delay? Is this an urgent case, or is this something that we need to track? Do they have comorbidities? And should we have a repeat visit? And all of these things overlap in this Venn diagram and give you your level of concern. So if we move on, What is your level of concern? Well, if we think about it like a stoplight, you have low to medium risk to moderately high risk, and then high risk level of concern. If you have no concerning features, that'd be your green light, good to go, right? Your decision is to begin a trial of physical therapy. If you have a few concerning features, well, we can begin a trial of physical therapy and have watchful waiting. If there's some clinical concerning features, let's get them to an urgent referral, meaning they don't need to go to the emergency department, but maybe they should go to outpatient urgent care or schedule call their physician that day and see if they can get in pretty urgently, not to use the same word twice. And then finally, if there is an emergent or very high concerning features, that may be an emergency. That would be more life-threatening, cardiovascular, maybe some severe neurological, post-trauma, that sort of thing. And so we'll go over what some of those things are. So if we work our way through a clinical decision pathway here, a person is referred with musculoskeletal condition to your practice. That's great. You do your exam, you find no concerning features. You treat them as planned and monitor their symptoms. If they're progressing as planned, the treatment proceeds as expected and the patient is just discharged from care. Let's go. That's what we want. Okay? That is so many of our cases, and this is the norm. The rest of this stuff looks kind of scary and is not the norm. So let's go through it because you'll need to know how to manage it. If there are a few concerning features, well, let's consider watchful waiting. Initiate treatment and create a safety net for the patient. If their treatment goes as planned, continue to monitor their symptoms. Now we're back in the green category. If they're progressing as expected after that, treatment proceeds as expected and patient is discharged from care. Let's go. You guys are awesome. You guys are doing this. Ooh, there's some red on there now. That's not good. Okay, so if there's more concerning features, you're going to follow that red line out to the right and then down to the red box. Consider further investigation or referral. Likewise, if you have a person that's referred who has a few concerning features, but they're not progressing as planned, they may go into this red bucket. And then again, if there's someone who is progressing as expected, for instance, if I move my little mouse here and over, but instead of progressing as expected, they take a turn for the worst, consider further investigation or referral. The timing of this will depend on specific pathology, but may be urgent or same-day emergent. Refer to condition-specific sections for details, and if investigations are negative, consider further referral or restart treatment of physical therapy. Very good. So, what I'm going to do, let's move this out of the way. Let's talk about systemic red flags. Systemic meaning global red flags. These are things that on your exam might necessitate you going at least down that yellow box and maybe even the red box, okay? So if the patient report, this is straight from Dutton, by the way, history of the following on the left and what the possible condition that leads to those symptoms may be. So what I'll have you do, I'm not going to read through all of this. I think you guys can internalize this pretty well. And there's a lot of this stuff on here that we will get a little deeper in as we go along. But you can pause this here, read through, write down what you need to. If there's anything you don't understand, write it down, shoot me a message. Okay? Very good. The presence of any of the following findings during the patient history, systems review, and/or scanning examination may indicate serious pathology requiring medical referral. Fevers, chills, or night sweats. These are signs and symptoms are almost associated always with a systemic disorder such as an infection. Okay, it could be flu, could be COVID, could be staph, could be stuff we don't even really know about in PT. Okay, but we do know that someone comes in with fevers, chills, or night sweats. That's not normal. If we move on, recent unexplained weight changes. And unexplained weight gain could be caused by congestive heart failure, hypothyroidism, or cancer. And unexplained weight loss could be a result of gastrointestinal disorder, hyperthyroidism, cancer, or diabetes. And so good old cancer, could make you gain weight or lose weight, and you'll see it also makes the body do a lot of other weird stuff. So cancer is one of the things we try to screen for. And we'll talk about that more, hopefully, later in this. Why don't we just do it now since we're on the topic? Cancer is one of those things that if you're doing a red flag screen and someone has, 4 out of 5 things that might make you question if they have cancer, do you tell the patient that they have cancer? I'll let you guys think about that one. Is it your job as a physical therapist to try and make a determination based off of clusters of tests and to have the confidence to tell a patient they have cancer? The answer is obviously no. Okay, so how do you manage that? Someone comes in, they have a ton of red flags. You tell them what their red flags are. You say, these things don't add up for a musculoskeletal condition. This is outside of my scope of practice. We need to refer you to a physician. The physicians are the ones who need to be able to communicate that to the patient. They'll do extra testing and they'll confirm it through more sensitive and specific measures than just questionnaires and things like that. So please don't ever tell your patient they have cancer. If they do have cancer, they will find out that they have cancer from the right person in time. Okay, perfect. Let's move on. Okay, malaise or fatigue. These complaints, which help determine the general health of the patient, may be associated with a systemic disease. So if someone comes in otherwise healthy, let's think about long COVID, for instance, okay? Long COVID patients otherwise should be healthy. They come in, they have a sense of fatigue, maybe they're short of breath, maybe their vital capacity, meaning how much air they can push out of their lungs and into their lungs, is decreased based on their current age with norms. Okay, so things like that, malaise or fatigue, could be a red flag. All right. Unexplained nausea or vomiting. This is never a good sign, needs medical workup. If you're having nausea for no real reason and you've been vomiting, you may have some GI issue. Maybe it's neurological. Maybe there's something wrong with, your central nervous system where maybe it's vertigo, right? Things like that can cause nausea and vomiting. And many other things that I don't even know about yet. So, nausea and vomiting, if they come in, I've been puking all night. Yeah, you're not going to do PT today. I think you should go to urgent care. Okay? Unilateral, bilateral, or quadrilateral paresthesias. The distribution of neurological symptoms can give the clinician clues as the structures involved. Quadrilateral paresthesias always indicates the presence of central nervous system involvement. That is a bad one. That's more, central nervous system, meaning brain, spinal cord. Unilateral, right? There's a lot of unilateral paresthesias, nerve entrapments, radiculopathy, things like that. Bilateral obviously is more concerning because it's more more volume of tissue affected, right? So if you have things going down both limbs, whether it's your legs or your arms, that may indicate, especially in the presence of, say, let's call it a disc bulge, a more central disc bulge, which can push on the cord and give you, bilateral radiculopathy. But we're looking out for things like myelopathy and trying to determine if this patient is even appropriate for physical therapy if they're having multiple limb paresthesias. All right. Shortness of breath. This can indicate a myriad of conditions. Just think, cardiovascularly, asthma, the list goes on and on what can cause shortness of breath. So it could be anxiety, psychosocial factors, could be pulmonary, cardiovascular. So definitely want to investigate shortness of breath. Could be just general deconditioning. How about dizziness? We get a lot of referrals to physical therapy for dizziness. This could be post-concussion, whiplash. It could be vertigo, right? So those are all things we can help treat. But the differential diagnosis of dizziness can be quite challenging. Patients often use the word dizziness to refer to feelings of things like lightheadedness or various sensations of the body orientation, blurry vision, or weakness in the legs. So dizziness to a patient is more of a bucket term, or we should think of it that way, rather than dizziness to us means actual like room spinning sensation, right? It can mean that to the patient, obviously, but it could mean other things. So you have to just dive a little deeper on your questioning. Nystagmus. This is characterized by a rhythmic movement of the eyes with abnormal shifting away from fixation and rapid return. Failure of any one of the main control mechanisms for maintaining steady gaze fixation results in disruption of steady fixation. So this could be a neurological condition as well, and we see this a lot in vertigo, obviously. And if you haven't seen this yet, I encourage you, just YouTube nystagmus vertigo, and you'll see someone wearing video, binoculars essentially, and those are for the clinician to watch their eyes beat. All right, it helps determine where treatment needs to be taking place. If we move on to bowel or bladder dysfunction, this is a big one. This is a big quality of life issue. This is embarrassing for patients to talk about, but it needs to be brought up and talked about if you feel like something like this is going on. Okay, or you want to know to add to your clusters of subjective testing to figure out, a red flag pathway, essentially. So bowel and bladder dysfunction may indicate compromise of the cauda equina. We'll talk about what that is more a little later. Cauda equina syndrome is associated with compression of the spinal nerve roots that supply neurologic function to the bowel and bladder. A massive disc herniation may cause spinal cord compression to this area. One of the early signs of cauda equina compromise is the inability to urinate while sitting down because of the increased levels of pressure. So it's actually urinary retention when we think about bladder dysfunction, not urinary urgency. So retention is more concerning than urgency. Maybe not more concerning, but maybe more concerning in this specific example of cauda equina. The most common sensory deficits occur over the buttocks, posterior superior thighs, and perianal regions. This is the so-called saddle anesthesia that you guys may have heard about. Rapid diagnosis and surgical decompression of this abnormality are essential to prevent permanent neurological dysfunction. So that's kind of a scary last bullet. Right, rapid diagnosis and surgical decompression. So if someone comes in and they have saddle paresthesias and they're also having some other weird symptoms down their legs, and maybe your exam has told you that there's a cluster of tests here. This should be unsurprising to the patient that something weird is going on. So this is a case where I would send them to the emergency room. Okay. Cauda equina is something, if I'm suspicious of that, I'd rather them go to the emergency room and be in the hands of those medical providers than be in my clinic. All right. Severe pain. Severe pain, like 12 out of 10 on the scale, person can't hardly sit down. They're in so much pain. They can't talk to you because they're in tears because they're hurting so bad. Right? Obviously, there's maybe some psychosocial stuff going on because being in that much pain affects the way you communicate. It affects your psyche. It affects you physically, obviously. But severe pain or an insidious onset of severe pain with no specific mechanism of injury is definitely a red flag. Could be, like I said, psychosocial. It could be something internal, that we don't even know how to screen for. It could be, who knows, maybe someone's, gallbladder ruptured. Okay. Insidious onset of severe pain. Dude, you need to get that checked out. Don't know what that is. All right. Pain at night that awakens the patient from a deep sleep. This is usually at the same time every night, and which is unrelated to a movement. This finding may indicate the presence of a tumor. If they have painful weakness, the presence of a painful weakness almost always indicates serious pathology, including but not limited to a complete rupture of contractile tissue or nerve palsy. So, we think about doing resisted isometrics. You could have strong and pain-free. You have strong and painful. You could have weak and painful, or you have weak and pain-free. So weak and painful maybe raises your clinical suspicion of something more serious going on. Let's just say someone was playing pickup basketball. They went to step back. They felt something in near their heel, had a sharp pain. Now they have trouble pushing off. And when you do your exam on the table, you notice that, their gastroc strength is weak and it's painful. But you can palpate and you're suspicious of maybe an Achilles tendon injury, rupture. You can palpate the Achilles tendon. You do some things like your Thompson test. Everything looks like it checks out, but there's still a lot of pain and they're weak. Well, look, man or woman, I think that this is a change in status. I'm not quite sure what's going on. You said you felt a pop. You're having a lot of pain. You're weaker today. I think you need to get this looked at. Sure enough, some of these cases come back and they're what's called plantaris ruptures, right? You have that small, skinny tendon that runs down from plantaris, attaches to the calcaneus, and this is something that feels like an Achilles tendon rupture. So that would be an example of where you go, okay, someone's having maybe some sort of contractile tissue issue. They're painful and they're weak. And so the way that's managed is they don't really do anything for that. They just let that tendon, that small little skinny tendon rupture, and your gastroc and your soleus provide 99% of the strength for your calf anyway. But it's good to know pathologically that the Achilles tendon's okay. So that's one example. There's many we could go over. If they have a gradual increase in intensity of the pain, this symptom typically indicates that the condition is worsening, especially if it continues during rest. And radiculopathy. This is a neurological symptom associated with more than 2 lumbar, or you could say cervical, levels. With the exception of central protrusions or disc lesions at L4 through 5, disc protrusions typically only affect one spinal nerve root. Multiple level involvement could suggest the presence of a tumor or other growth or space-occupying lesion, and it may indicate symptom magnification, meaning their symptoms are worse in those cases. The presence or absence of objective findings should help determine the cause. If you like, you can pause it now and you can go on a little break. Otherwise, let's keep rolling. So, cervical spine red flags. So essentially what we're going to do next is break down certain body regions and red flags for those specific regions. Cervical red flags. First up, we're going to talk about cervical stenosis and myelopathy. This refers to compression on the cervical spinal cord. Any space-occupying lesion within the cervical spine that narrows the spinal canal has the potential to compress the spinal cord and cause cervical myelopathy. And think about what myelopathy is. I want you guys to look up the root words there. Obviously, we know pathy, right? But what does myelo mean? I want you guys to look that up. Spinal stenosis is predominantly caused by cervical spondylosis, or degenerative changes in the cervical spine, but can also be the result of traumatic, like fractures and instability, and inflammatory conditions, or caused by herniated disc or tumors. This article by Salvi et al. Is the assessment of cervical myelopathy. Still a good one, even from 2006. If you look at the table on the left side of the screen, you have clinical signs of cervical radiculopathy and myelopathy. Cervical radiculopathy is something that we treat all the time in physical therapy. Okay, so if we look at the columns and rows underneath there, and we're actually, I guess I can just help out and highlight here. So if we look here, you have your pathology. Plus means it's positive. Negative means it's normal. Cervical radiculopathy column, myelopathy column. So let's find our way through here. Muscle wasting. Yes, you could have unilateral muscle wasting in the hand or forearm in cervical radiculopathy. Myelopathy will be bilateral. Okay. Sensory deficits follows a pretty typical nerve root pattern in cervical radiculopathy, but not myelopathy. Your vibratory sense is diminished. Can you sense vibrations? No. or yes, rather, right, in radiculopathy, not in the lower extremities in myelopathy. Muscle stretch reflexes are weak. They're hypersensitive. So we think like a scale of 0 to 2 plus, right? A 1. Let's think about this. A 3 plus. A 2 plus is normal, right? So if you do reflexes and someone comes back and it's diminished, or a 1 plus, we may consider radiculopathy. If it's a 3 plus, or it's hypersensitive or hyperreflexive, we might think more myelopathy. Abnormal reflexes again. Here we go. And then Sperling's test, positive, right? Foraminal compression gives you symptoms down your arm. That's not the case in myelopathy. It's a more central nervous system. And then we get into more of your upper and lower motor neuron signs, Babinski sign, hypertonicity, gait deviations. Those are all positive in myelopathy. That's more serious. So we take a look at the cross-section here of the cervical spine. We notice is the disc, the central, the spinal cord here, and then you can see the nerve roots exiting. Obviously, this is the spinous process, transverse processes, etc. So this is what a normal, looks like. If we add in spinal stenosis, you can see that there's many different things that may occupy the space of the nerve leaving the foraminal opening here. One could be osteoarthritic spurs. So bone growth could impede on the space where the nerve's exiting the canal. Narrowing of the spinal canal itself through disc protrusion. And if you have a combination of the two, you can see you're getting squeezed between a rock and a hard place. So that nerve gets pinched, you could have symptoms down that limb. Whereas in cervical myelopathy, there's something more involved with the central nervous system, and you get things shooting out bilaterally. Okay, hopefully that makes sense. If we move on, let's talk about cervical fractures. When a patient with neck pain reports a history of trauma, the therapist needs to be particularly alert for spinal fractures and the potential for cervical instability and or spinal cord or brainstem injury. The Canadian C-spine rule can be used to determine when to refer radiology in individuals following trauma where fracture of the cervical spine is a concern. So hopefully this is not your first exposure to Canadian C-spine rules, but let's go through this schematic. So this is developed obviously in Canada, but in emergency rooms there to try to determine when imaging is appropriate for cervical spine injuries. Because a lot of times cervical spine injuries are just strains or sprains. Low-grade sprains instead of high-grade, transverse ligament or alar ligament tears with, dislocation. So how do we determine? So if we work through the schematic here. 1, any one of the high risk factors which mandates immobilization. Are they greater than 65 years of age? Yes or no? Was there a dangerous mechanism? Yes or no? Or is there numbness, tingling in the extremities? Yes or no? If the answer is yes, you immobilize their cervical spine. Okay? If no, you move on to low risk factors. Was this a simple rear end motor vehicle accident? Or are they ambulatory at any time at the scene, meaning they got out of the car, walked around, called their insurance company, etc. Or no neck pain at the scene when you asked, or when they were asked, and no pain during midline C-spine palpation. If they answer no to these, and they're still having bad neck pain, you would immobilize temporarily, right? So you'd immobilize and then eventually you'd get imaging. So yes, if they answer yes to those, you're thinking, okay, this may not be as serious. Patient voluntary, able to actively rotate their neck to 45 degrees left and right when requested, regardless of their pain. Yes, good. They have good active range of motion. They're not complaining of any instability. It might hurt, right? But if they can't, they feel apprehensive to, or there's a literal mechanical block, then we need to immobilize and assume fracture, that sort of thing. So long story short here is, let's say you're treating a patient for their knee. They're far enough out where they felt comfortable climbing a ladder to get leaves. Well, you guys live in Arizona, but If you're not from Arizona, you understand that in fall sometimes leaves get in your gutters on your house. Okay, you can picture that. They slip, they fall off the ladder, land, and they kind of experience this whiplash injury. If they're over 65, we want to get them imaging pretty quickly because they fall into that category of, one, they're older, their bones are a little more brittle, and two, there's a dangerous mechanism. You also want to know if they have numbness or tingling. Okay, so if any of those things are present, then we get imaging right away. Immobilize, get imaging. Expect the worst. But again, if they're ambulatory, they get up, they're not sore that day, but they're sore the next day, you can work through. Do they have range of motion? If they don't, then you feel like, okay, maybe something's more serious going on. You get them into and see someone for imaging. Okay. Other dangerous mechanisms could include, if we look at the bottom right here, a fall from elevation, as we just described, axial load to the head, like diving, motor vehicle crash at high speed. This is 60 miles an hour, by the way. They got rolled over or ejected. Obviously, those are dangerous. Motorized recreational vehicles like ATV accidents or bike collisions. Simple rear end crashes excludes pushed into oncoming traffic, hit by a large bus or truck, rollovers, or hit by high-speed vehicles. So, if you're sitting duck, essentially, and you get nailed, we need to really consider that. That's a dangerous mechanism. All right, very good. Cervical spine red flags. What is CAD? It's cervical arterial dysfunction. This is an umbrella term covering a broad spectrum of potential vascular pathologies. It ranges from pre-existing underlying anatomical anomalies, vasospasms, atherosclerosis, through to giant cell arteriitis or arterial dissection. All of these may lead to potential cranial-cerebral ischemia, which may originate and manifest in a variety of ways. Could present in the following ways: pain, cranial nerve dysfunctions, sympathetic nerve dysfunction, blindness, stroke, or, too late to understand this, but death. Care must be taken to differentiate vascular sources of pain from musculoskeletal sources. Urgent medical investigation is indicated if frank vascular pathology is identified. And I would say that urgent means emergent. Okay? Talk about the 5 Ds, 3 Ns, and 2 As. This is a mnemonic to try to remember while you have a patient in front of you if something's up. The 5 Ds: dizziness, drop attacks, diplopia, dysarthria, and dysphagia. So we know what dizziness is. Drop attacks mean unexpected, not fainting necessarily, but unexpected loss of control of your nervous system where you fall. Okay? Feeling of unsteadiness, or random times where your body gives out on you and you literally fall. Okay? It doesn't necessarily mean fainting. Diplopia is double vision. Dysarthria, trouble speaking. Dysphagia is trouble swallowing. Okay? These, by the way, are all cranial nerve issues. Most of them. Maybe drop attacks is not. It's more central nervous system. The 3 Ns: nausea, numbness, nystagmus. Those all seem to make sense. And then the 2 As: ataxia, and then we lump in anxiety. Cervical instability. Clinical instability of the cervical spine is identified as the inability of the spine under physiological loads to maintain its normal pattern of displacement so that there is no neurological damage or irritation, no development of deformity, and no incapacitating pain. Okay? With cervical instability, particularly in the upper cervical spine, there is potential for serious neurological injury, so the cause and extent of instability should be investigated before physiotherapy treatment commences. So we go back, cervical instability. This would be more of those people from the Canadian C-spine rolls that eventually get immobilized. The reason we want to immobilize them is we want to make sure they don't have a upper cervical instability, because the consequences of treating someone in that state could be deadly. Again, you can pause here if you'd like, take a quick break, and we'll come on back. Hey guys, we're back. So thanks, I had to take a quick break myself. All right. Thoracic spine and ribs. Red flags of the thoracic spine and ribs. Again, I'm going to let you guys pause the video and look over this, but we'll just go over the conditions and the red flags. Some of these I really want you to know. Some of them I want you to know. Obviously, I want you to know them all. But some of them I want you to know a little more intently because they're a little more common. Okay. So MI, myocardial infarction. Red flags are chest pain, pallor, sweat, dyspnea, nausea, palpitations. Risk factors of heart attack include previous history of coronary heart disease, hypertension, smoking, diabetes, elevated blood serum cholesterol levels, men aged 40 years and women aged over 50 years, and symptoms lasting longer than 30 minutes but not relieved with sublingual nitroglycerin. Stable angina pectoris. This is chest pain or pressure that occurs with predictable levels of exertion. Symptoms are also predictably alleviated with the rest or sublingual nitroglycerin. Pericarditis, again, I'm going to let you guys read through this. Pulmonary embolus, pleurisy, and a pneumothorax. This is one that you might actually see in clinic. All these, obviously, you might see in clinic, rarely, but hopefully you never do. Pneumothorax is one. You could certainly see this on a field covering a sporting event. Chest pain that is intensified with inspiration, ventilation, or expanding rib cage. Recent bout of coughing or strenuous exercise or trauma like a hit in football. Hyperresonance upon percussion, and then decreased breath sounds. You also notice that as they inhale, they might get deviation of their trachea to one side or the other. Again, this is all in Dutton. Pneumonia, cholecystitis, peptic ulcers, pyelonephritis, and nephrolithiasis, kidney stones, right? I know them as kidney stones, so forgive me for my medical terminology mess up there. Anyways, I want you to read through these. The big ones in this section are going to be myocardial infarction and pulmonary embolus and pneumothorax. Okay. Vertebral compression fracture is also a big one in the thoracic spine. This occurs when the bony block or vertebral body in the spine collapses, which then leads to severe pain, deformity, and loss of height. It's most common in the lower thoracic spine. So causes of this are severe osteoporosis or even moderate osteoporosis. It is most common fracture in patients with osteoporosis, affecting about 750,000 people annually. Vertebral compression fractures affect an estimated 25% of all postmenopausal women in the U.S. The occurrence of this condition steadily increases as people age, with an estimated 40% of women age 80 and older affected by this. People with healthy spines most commonly suffer from this through severe trauma such as car accident, sports injury, or a hard fall. But also metastatic tumors should be considered as the cause in patients younger than 55 with no history of trauma or only minimal trauma. The bones of the spine are a common place for many types of cancers to spread, and the cancer may cause destruction of the part of the vertebral body, weakening the bone until it finally collapses, even with something like sitting down. So, vertebral compression fractures continued. The main clinical symptoms of these may include, in standalone or in combination, sudden onset of back pain, an increase of pain intensity while standing or walking, a decrease in pain while lying on your back, limited spinal mobility, eventual height loss, meaning literal shrinking of your height, and then eventual deformity and disability. These are typically the people that have this going on. They look something like this. Overweight, sedentary, and elderly, and typically women. Just because of postmenopausal factors, not because they're a woman, but because of more biochemical reasons as well that may cause osteoporosis or bone weakening. Okay? So let's talk about now the lumbar or low back red flags. A back-related tumor. This could be cancer or metastasis to the spine. The big red flags here are age over 50, history of cancer, unexplained weight loss, or failure of conservative therapy. Someone comes in with back pain, they don't get any better after 6 weeks of treatment. It's like maybe something else is going on. Back pain related infection. This is called spinal osteomyelitis. It's a recent infection, like a urinary tract or skin infection, is a red flag. Intravenous drug user or abuser, and concurrent immunosuppressive disorder. Cauda we talked about this earlier. Urinary retention or incontinence, usually more on the retention side. Fecal incontinence, saddle anesthesia, global or progressive weakness in the lower extremities, sensory deficits in the feet. And just as a mention here, any one of these things in isolation, right? Age over 50 means nothing, right? Doesn't mean you're over 50, you have back pain, dude, you got cancer and Mets to the spine. No, right? This is where we mean these clusters of red flags add up to give you an idea of something maybe more serious going on. Failure of conservative therapy. No, you don't have cancer. You just didn't respond well. You need some different type of treatment. See where I'm going with this? So don't just assume. Really try to figure this out. Let's talk a little more about cauda equina syndrome. This is a space-occupying lesion of the cauda equina. The cauda equina is the base of your spinal cord, where all of it, your lumbosacral plexus, essentially, where all the nerves spread out. It's called that because it looks like a horse's tail, and that's what cauda equina means. But there's distal emergent symptoms, which include, as we just mentioned, urinary retention, fecal incontinence, saddle anesthesia, progressive or global weakness in the lower extremities, and sensory deficits in the feet. Let's get into pelvis, hip, and thigh red flags. Again, cancer is a big one, right? Colon cancer. So age over 50, bowel disturbances like rectal bleeding or black stools, unexplained weight loss, history of colon cancer in immediate family, or the pain is unchanged by positions or movement. Okay, that's always a red flag too, is pain unchanged by positions or movement. Makes you maybe think it's not orthopedic in nature. How about pathological fractures of the femoral neck? This is a big one in elderly, especially women again. Any bone fracture issues, usually going to be elderly women that deal with this the most, but don't rule out elderly men or just men maybe with poor health or women with poor health. So the history of a fall from a standing position, severe constant pain is worse with movement, and a shortened and externally rotated lower extremity, meaning there's a visible deformity to their leg, and you correlate it to them having pain in their hip. And maybe there's a history of a fall, right? All those things are like, ooh, hip fracture, not good. Osteonecrosis of the femoral head, aka avascular necrosis. So history of long-term corticosteroid use. It's like patients with rheumatoid arthritis or systemic lupus or asthma. They may have used corticosteroids for a long time. That can infect the blood supply to the hip, leading to this. A history of avascular necrosis of the contralateral hip, and then trauma. I forget the stat, but it's something like, gosh, I don't want to throw a number out there. A lot of cases, if you have avascular necrosis in one hip, it's like you're probably going to get it in the other hip. And so these patients get hip replacements. That's how you treat it. So as we are nearing the end of our lecture here, how do you screen for red flags in the clinic? We talked about at the beginning your subjective history and your examination and things like that. But how do you actually screen for it? Okay, this could be part of your intake paperwork. George et al. Came out with a paper looking at a screening tool called the OSPRO. Okay, this stands for the Optimal Screening for Prediction of Referral and Outcome. And their whole goal is to try to look at several different of those red flag symptoms, and see which are the most consistent with being insidious in nature. Okay? You'll get access to the articles that are in this presentation as well, so you can read through them. So, the OSPRO Red Flag Symptom Item Bank looks something like this. Let me move this guy out of the way. So a lot to digest, okay? You'll have access to the article. You can read through it as well. But you can pause it here and look through. So items in bold font have been described as general health, constitutional symptoms, or general systemic, but were classified with a specific system for the purpose of this item bank, okay? So what they did was they broke down different body systems: cardiovascular, pulmonary, GI, urinary, endocrine, nervous system, integumentary, and musculoskeletal. And in each one of those different systems, they asked all of these questions to patients. And what they found, if we go on, is that there's the top 23 are listed here, meaning a cumulative positive red flag responders identified, a total of 393 patients. And what's listed here is how many people out of the 393 listed each individual response, meaning out of 393 people, 161 said that they had recently experienced abnormal sensations, numbness, pins and needles, etc. So your increase in positive red flag responder per item is 161. Then the second question that was indicative is, have you recently experienced headache? 59 people in this study responded, bringing the total to 220. And you can see how we worked through 287, 314. So 393 people. So you can see the vast majority of people fall into the first 10 questions. So if we get down here, questions 11 through 23, all single digit people responded. So we're thinking that maybe our efforts in screening subjectively for this stuff should go into the first 10 questions. So this is important for a couple of reasons. One, we know that patients don't like filling out tedious paperwork, but we want to get a serious idea of their symptoms. So if we can have the best of both worlds, where we have a 10-item questionnaire versus a 50-item questionnaire, where they're going to circle no to 90% of it likely anyways, versus this that might actually open the door for conversation, then we can break off and ask those questions that they might have otherwise just circled no anyway, right? Or if they circled yes to one of these, we can dive deeper into their situation. If this does not make sense to you, then I want you to reach out to me, because the way I'm explaining it might not be conducive to some of your guys' learning style. This is a little bit of a complicated paper in the sense that they looked at all of these different factors, and let's try to keep it simple. They looked at all these different factors, and they're trying to come up with what's the most, the biggest bang for your buck, the low-hanging fruit questions that might open the possibility for conversation deeper into it. So what they noticed is that for 372 out of 393 people, the first 10 questions listed here were the most important, okay? So let's just go through them. Have you experienced abnormal sensations, headaches, night pain, sustained morning stiffness, lightheadedness, trauma, night sweats, constipation, easy bruising, or changes in vision? So I challenge you guys to think through those first 10 questions and figure out which body system might be most affected by those. Of course, you can look on to questions 11 through 23 as well, and see what you think about those. So I highlight at the bottom, the review of systems tool comprised the first 10 items had 94% accuracy. 372 out of 393 people. And the 23 questions had 100% accuracy. All right. So let's talk about some case studies. This is something that you guys are going to do independently. This is that article that we went over at the beginning, the framework for red flags for potential serious spinal pathologies. In the back half of this article, they have several case studies to help you work through what we would consider questions that are going to be like test questions on red flags. So you'll work through a case. They'll present something to you. They'll present a case to you, and you have to determine if, based on the information they give you in the test, if they're appropriate for therapy, need to be referred out, or treat and refer. Okay, so there's several case studies. I want you guys to work through those, understand them, talk with your classmates about those case studies. So I just want to say thank you. Appreciate it. I know this lecture, red flags are always a little tedious, but very important information. I really look forward to helping you guys out this term. Again, thank you for allowing me to be a part of this class. It's nice to be back. I was a professor. I don't know if Dr. Heffron or Harris told you. I was a professor about 4 years ago at Franklin Pierce, and ever since I've left, I've really missed it. Currently do some teaching up here in the Twin Cities in Minnesota, where I currently live with my wife and family. And it's nice to be back kind of on this hybrid or mixed style lecturing style. So anyways, appreciate you guys. Please reach out with any questions, and we'll get to you some information on office hours and stuff as well. So thank you so much.